Today we will take ENT, starting with the anatomy. Now, ear has three parts: external ear, middle ear, inner ear. The the external ear. One of the important question is about the nerve supply of external ear, right? So as you can see, we can discuss the nerve supply either from outer or lateral aspect, or we can discuss the nerve supply from the behind or the medial aspect, right? So if you look in the lateral aspect, one nerve is auriculotemporal nerve, right? So auricle is external ear actually. So auriculotemporal. Then the green portion is supplied by two nerves, the 7th and the 10th. Clear? So 7th and 10th, and for 10th especially one branch is the auricular branch, which is also known as Arnold's nerve, right? So 7th and 10th, and then another important branch is great auricular nerve, right? So these are different branches, different nerves which supplies the external ear on lateral aspect. Coming to medial aspect, there is no auriculotemporal nerve. In fact, there is one lesser occipital nerve, right? So no, or instead of auriculotemporal, you have to remember lesser occipital. Apart from that, the remaining nerves are same, the 7th and 10th and the great auricular nerve, right? So these are the different nerves which supplies the external ear, and this is an important segment from where questions are usually asked. So in the lateral aspect, especially anteriorly, there is auriculotemporal, then vagus through its auricular branch, which is also known as Arnold's nerve, and then facial and great auricular nerve, right? So these are the nerves which are supplying the auricle or the pinna, you can say. Then moving forward to another important topic, that is external auditory canal. Okay, so you can see this is the external auditory canal. Now the overall length is 24 millimeter, but this is not same in the entire length. Obviously the inner part will be bony, right? So the inner part is bony and the outer part is cartilaginous. Clear? So this part is cartilaginous. Now it's very easy to remember outer part is cartilaginous because this is pinna, and pinna is made up of elastic cartilage, right? So this is all elastic cartilage. So you can remember this elastic cartilage of pinna is continuous with the cartilaginous portion of outer 1/3 cartilaginous portion of the external auditory canal. And remember one thing, the lobule is devoid of elastic cartilage. It doesn't have elastic cartilage, right? So just remember this much, does not have elastic cartilage. Clear? So this is how you can remember the outer 1/3 is cartilaginous and the inner 2/3 is bony, right? So I hope you won't make any mistake in this. So outer 1/3 is cartilaginous and inner 2/3 is bony, right? So this is 8 millimeter and this is 16 millimeter. Now this outer part is having hair, okay, and ceruminous glands, skin is thick. So anyway, so this is external auditory canal. Then the medial part of this canal is tympanic membrane. So this is the tympanic membrane. Now tympanic membrane, if you see, it has two parts. One part is the tense part, so this is known as pars tensa. Okay, this is all pars tensa, and the upper part is flaccid, and this is known as pars flaccida. Clear? So pars flaccida, pars tensa. Is that clear? And if you throw light, and you can divide it in like 4 quadrants. Say this is anterior superior, this is anterior posterior, this is anterior inferior, and this is so this one is wrong. So this one is posterior superior and this one is posterior inferior, right? So these are the 4 quadrants. Now if you throw light, you can see a cone of light. So this is the cone of light, and this is present in the antero-inferior quadrant. Clear? So this is the antero-inferior quadrant. So there is a cone of light which is present in the antero-inferior quadrant. Now tympanic membrane, if it is like this, there are 2 surfaces. One is lateral surface, and this is towards the external auditory canal, and inner side there is one medial surface, and this medial surface is towards the middle ear. So this one is towards the middle ear and this one is towards the external auditory canal. Now this lateral surface is again having the same nerves, the same nerves which are supplying the external auditory canal, namely the auriculotemporal nerve and the auricular branch of vagus. Clear? So these are the 2 nerves, auriculotemporal nerve and auricular branch of vagus nerve. This is on the lateral aspect. But if you talk about the medial aspect, the middle ear is all supplied by glossopharyngeal nerve, right? So different sites, different nerve supply. Just remember that. And usually it is pearly white in color. Then moving forward to middle ear. Now the middle ear, it has 3 divisions in relation to the tympanic membrane. The area above the tympanic membrane is different, the area below the tympanic membrane is different, and the area which is just opposite or just medial to the tympanic membrane is different. So this is known as epi, this is hypo, and this is meso, and you need to add the word tympanum with all these divisions. So tympanum here. Clear? So epitympanum, mesotympanum, hypotympanum, right? So that is the division. Now epitympanum, which is also known as attic. Now I think all of you must be knowing what does epi means. Epi means above. So above the level of tympanic membrane. So this is all epitympanum. Similarly, hypo means low. So this is all hypotympanum. And the one which is exactly medial is mesotympanum. Now this attic or epitympanum is very important because it is in more proximity to the mastoid antrum, right? So this is epitympanum, and there is one Prusax space in this epitympanum. Out of the 3, mesotympanum is the narrowest, and mesotympanum is just medial to the tympanic membrane. Okay, so epitympanum, mesotympanum, hypotympanum. Now middle ear can be considered as a 6-sided box, and different like there are 4 walls, 1 roof, 1 floor, so it's a 6-sided box, and of course the lateral wall is formed by the tympanic membrane. So if we remove the lateral wall, like this is the lateral wall, so this is tympanic membrane. So if we remove it, we can see the interior of the middle ear cavity, and here this is anterior, okay, this is floor, here roof. Clear? The one which we see is actually the medial wall, okay, and then this one is the posterior wall. In the anterior wall we can see 2 important openings. One is for one muscle, and that is tensor tympani. So this is opening for tensor tympani here, and there is one more opening, and that is for the Eustachian tube, which connects the middle ear with the nasopharynx, right? So these are the openings in the anterior wall. Posterior wall, we can see one oval window, one round window, and then promontory, which is because of this prominence of the coils of cochlea. And then posteriorly we can see Otitis to antrum, and there is one pyramid on which is related to the stapedius muscle. Clear? And then we can also see the facial nerve canal. Clear? So this is the canal for facial nerve. So these are different structures, but what is more important clinically is the roof. So this is the roof here, and this roof is formed by the tegmen tympani bone. Okay, so tegmen tympani. Now why it is so important? Because suppose this is the roof, below this is all middle ear, and above this is all cranial fossa, and we know that there is CSF in it, right? So there is CSF here. So this is CSF. So what I mean to say, like if there is any fracture involving tegmen tympani, this CSF can leak out into the middle ear and it will come out through the ear. The condition is known as CSF otorrhea. Clear? So that's why we always prefer discussing about the roof of the middle ear. Then there is one muscle, stapedius. It prevents hyperacusis by dampening the intensity of the sound. Moving forward to inner ear, there are two, it is actually labyrinth, and there are two components, the outer bony labyrinth and the inner membranous labyrinth. Now in the outer bony labyrinth you can see three semicircular canals, then vestibule and the cochlea, and the membranous part is actually all duct system like semicircular ducts, atrial, saccule, then cochlear duct, and then ductus reunions and endolymphatic duct and endolymphatic sac. So these are the parts of membranous labyrinth. Now the function of semicircular canal is to judge angular acceleration, and the atrial and saccule, they judge the linear acceleration. I think most of you must be knowing already this. Now if we take a section through the cochlear turns, we will see three areas. The upper one is scala vestibuli, the lower one is scala tympani, and the middle one is scala media. Clear? Now scala vestibuli and tympani, they contain scala vestibuli, scala tympani, they contain one fluid that is known as perilymph, and scala media contains a fluid that is known as endolymph. Now this endolymph is secreted by stria vascularis. Clear? So if you see here, this is all stria vascularis which secretes the endolymph. And then we can also see the organ of hearing, that is the organ of corti, which is resting over a basilar membrane. Clear? So this is the arrangement of structures in the cochlear duct, right? Then perilymph is similar to ECF, and endolymph is similar to ICF in composition. Now when we say ECF or extracellular fluid, it is rich in sodium, and when I say extracellular fluid, it is rich in potassium. Clear? So just remember like that. So perilymph is similar to extracellular fluid, so rich in sodium. Then this is the organ of corti, which is the organ of hearing, and it is resting on a basilar membrane. Then moving forward to Eustachian tube, we discussed that there is an opening in the anterior wall of the middle ear which gives opening to Eustachian tube, and another opening is in the nasopharynx. Now this tube develops from the first pharyngeal pouch, and usually it is closed, but it only opens up during whenever there is increase in oral cavity pressure. It can be yawning, sneezing, swallowing. So it opens up only that time, and the muscle which opens up is tensor palati. Clear? So normally it remains closed. Now if you look in the diaphragm, so this is the Eustachian tube, right? So this is the Eustachian tube here, and it is opening in the nasopharynx, and this is opened up by the tensor veli palatini or tensor palati. Then it is connecting the nasopharynx with the middle ear. Clear? And then we can see the mastoid ear cells. These are all mastoid ear cells, and this one is the external auditory canal. Clear? So this is external auditory canal. Fine. So this is the arrangement of this Eustachian tube. Now if we talk about the dimensions, the length of Eustachian tube or pharyngotympanic tube, this is 36 millimeter, and just like external auditory canal, it is also composed of two portions. So the inner one is bony, and the outer 2/3 is cartilaginous. So this is bony and this is cartilaginous. So here bony is 1/3 and cartilaginous is 2/3. Now you can recall external auditory canal as well, where the cartilaginous was 1/3 and bony was 2/3. So here it is reversed. Clear? So just make sure that you don't mix up between the two. Now moving forward to some diseases. Otitis externa, it means inflammation of external ear. If the word is simple otitis externa, the answer has to be Staphylococcus aureus. But if the term is malignant otitis externa, you have to answer Pseudomonas aeruginosa, right? And this condition is especially seen in elderly diabetics who don't take their medicines regularly and their sugar level is not well controlled. And we can see granulation tissue. Sometimes there can be facial nerve palsy as well, right? So there can be facial nerve palsy as well. So the word malignant is there, but it is not a tumor. Clear? So this is malignant otitis externa. Then otitis media, again inflammation of the middle ear, and one of the important condition is serous otitis media, which is also known as secretory otitis media or glue ear, or otitis media with effusion. Clear? So this is secretory otitis media. Now what is happening here? There is collection of fluid in middle ear, and this can be seen in some conditions like nasopharyngeal carcinoma. It can be seen in adenoid hypertrophy. Clear? And here there is no inflammation as such as we see in ASOM, and there will be conducting hearing loss. Clear? So there is conductive hearing loss, and that's why the teacher will complain that the child is inattentive in school, right? But the reality is that the child is having deafness. And when you look at the when you will do otoscopic examination, you will find middle ear, or you can see air bubbles or air fluid level in middle ear. Clear? And then there is B-shaped tympanogram, and since there is no inflammation, so antibiotics has no role. Clear? So there is no role of antibiotics. Now what we need to do? We need to give an incision, that is myringotomy, and we need to put a grome or a ventilation tube. Clear? So this is the treatment for serous otitis media. Then acute suppurative otitis media can go into chronic suppurative otitis media, and here we have two varieties depending on the location of perforation. It is either safe variety, which is having central perforation, and the one is unsafe, which is having attic or marginal perforation, right? So this is safe and this is unsafe. Now we call it unsafe because there is one complication which can be seen here, and that is cholesteatoma. Clear? And apart from this, there can be granulation tissue, right? So this is important here. And the type of discharge is scanty, foul smelling ear discharge. Clear? In safe, there are no complications like this. So cholesteatoma is absent and the discharge is copious. Clear? So this is like safe and unsafe. Obviously, out of the two, unsafe is very problematic. And now coming to complications, the most common complication is mastoiditis, and the second most common is brain abscess. And in fact, the most common cause of brain abscess is otogenic in origin. It means it is related to chronic suppurative otitis media. Then there can be pus in relation to sternocleidomastoid muscle, and this is known as Bijolt's abscess. Clear? So this is Bijolt's abscess. Then there is one Grade-Nigo syndrome in which there is retroorbital pain, photophobia. Retroorbital means behind the eye, photophobia means sensitivity to light, lacrimation. Then fifth and sixth nerve, cranial nerve involvement along with CSOM. Right? So this is Grade-Nigo syndrome. And as we said that unsafe is associated with cholesteatoma, it has a tendency to involve the temporal bone, especially the petrous temporal, and the type of perforation is of course the attic or the marginal type of perforation. And treatment wise, we need to do MRM, that is mastoid radical mastoidectomy. Now one of the characteristic signs of one complication, that is LST, that is lateral sinus thrombosis, is Griesinger's sign, in which there is edema and tenderness over the mastoid process. And for lateral sinus thrombosis, we can do one test that is known as Tobey-Ayer test, where what we do a lumbar puncture, we connect the CSF column to a manometer, and then we press the internal jugular vein. Now when the internal jugular vein is pressed, the pressure should be transmitted till this column, and there should be a rise in the CSF column. Clear? But what happens if there is any blockage anywhere? So this pressure which is generated by compressing the internal jugular vein, it will not be transmitted to the CSF column, and there will be no rise. So this is the Tobey-Ayer test, which checks if there is some blockage anywhere in the lateral sinus or not. Then moving forward to Otosclerosis, it begins in one landmark, that is fistula antifenestrum, and especially involving the oval window related to stapes. Now the patient will present, usually a female, it presents with a positive family history. Since there is defective conduction of sound, so it is presenting as conductive hearing loss. And although the patient is having conductive hearing loss, but when he is in a noisy surrounding, his hearing will improve. Why? Because what happens in noisy surroundings, patient will speak louder. So the yes, Mohammad Anas, very good. So what will happen? The patient will the persons will speak louder, and the patient takes the advantage of that, and he'll hear better. So this term is known as paracusis willisii, and this is the improved hearing in case of noisy surroundings. Apart from that, in a Carhart's notch, you can see a dip at 2000 Hertz, And then especially in active phase of the disease, we can see a flamingo pink tympanic membrane. Treatment wise, yes, we need to remove the stapes and we need to put a prosthesis. So stapedectomy plus prosthesis. And sometimes we can try sodium fluoride to retard the progression of the disease. Then moving forward to Meniere's disease, and here you can see there is excess of endolymph, and this is causing dilatation of the cochlear duct or the endolymphatic sac. So this is also known as endolymphatic hydrops or somewhat like ear glaucoma, and this is because of increased endolymph. So there is more production or defective absorption. Now from exam point of view, student, yes, Anas bhai, absolutely right, this is just like glaucoma and therefore it is known as ear glaucoma. The triad can be remembered by the mnemonic DVT. So D is deafness, especially low frequency sensory neural deafness, then V is vertigo, and T is tinnitus. And again there is the pathology is that there is dilatation of the membranous labyrinth. So this is in short about Meniere's disease. Then moving to Bell's palsy, this is a lower motor neuron type of lesion. So what you will see, complete one half of the face is paralyzed, right? So complete one half of the face, and this is ipsilateral. So if I say very good, lower motor neuron lesion, yes, this is lower motor neuron lesion. So suppose if there is left facial nerve palsy, then the patient will develop paralysis of left half of face. Clear? So this is Bell's palsy, and we can just note down 2-3 things here. There is there is drooping of the angle of mouth on the affected site. Then there is loss of furrows on the forehead. Then if you tell the patient to close the eyelids, the eyelid cannot be properly closed. So these are few tests which you can do. So overall the thing is that loss of muscles function which are especially related to facial expression, because these all are supplied by facial nerve, right? So this is in short about Bell's palsy. Unilateral means one-sided, and more better this is ipsilateral. Unilateral but ipsilateral, and this can come all of a sudden, may be seen especially in persons who are diabetic or who are prone to malignant otitis externa, as we discussed before. Yes, Muhammad Anas, absolutely right. Forehead furrowing will be lost. Then moving forward to acoustic neuroma, which is also known as vestibular schwannoma. It usually arises from the superior vestibular division of the 8th nerve. And see, earliest symptom is related to ear, that is deafness, especially retrocochlear type. But the earliest sign is different, and earliest sign is related to the 5th nerve, and that is loss of corneal reflex. It means if you touch the cornea with a wisp of cotton, there won't be blinking at all. So this is very strange that symptom is related to 8th nerve and sign is related to 5th nerve. Clear? So that's very unique or very strange. Now we can do gadolinium MRI of head region. Yes, Anas bhai, absolutely right. Then moving forward to one important investigation, and that is BERA, or you can also write it BER, like brainstem auditory evoked responses. And this actually helps us in differentiating the site of sensory neural hearing loss. So what you can see here, you can see a few waves, 1, 2, 3, 4, 5, 6, 7, and these waves actually they are generated from different part of the neural pathway of hearing. So the one is from the wave 1 is related to cochlear nerve 8th, right? Then also you can remember one mnemonic here, if you can Clear? So you can remember this mnemonic first, so that will help you in understanding. So S is superior olivary complex. Clear? Then L is actually the lateral lemniscus. Remember, medial lemniscus is related to dorsal column. Then I is inferior colliculus, and M is for medial geniculate body. The lateral geniculate body is related to vision. So here you can remember one mnemonic, slim, and after this, of course, the last is the auditory cortex. Clear? And before this, you can remember the nuclei of cochlear. So cochlear nucleus, and of course the starting point is cranial nerve 8th. So this way you can give the numbering. So 1, 2, 3, 4, 5, 6, 7. Right? So remember this, and I think you will never be wrong in your answer. Right? So this is Bera, and sometimes we have a question about the waves, like they are generated from which part of the pathway. Okay. Then moving forward to tuning fork test, and this test shown in the picture is a Rennie's test. And what we are doing here, in first step we are checking for bone conduction, and in the second we are checking for air conduction. Clear? So we keep the tuning fork at the mastoid process, and we will ask the patient whether you are hearing the sounds or not. Once he says that I am not hearing, then we will take it out and we'll put it in the front of the external ear. And in a normal subject, one should be able to hear when the tuning fork is kept or placed in front of the external ear. Right? So this is normal. But this kind of presentation can also be seen in sensorineural hearing loss. So if the test is positive, now this is a positive test. If the test is positive, it can be a normal person or it can be a case with sensorineural hearing loss. Right? Now, obviously, if it is negative, it's pretty easy to say that this is a case of conductive hearing loss. So suppose if the patient is coming to you with deafness in the right ear, and if you do a tuning fork test and you find that bone conduction is more than air conduction, you can say that in the diseased ear there is conductive hearing loss. But in this case, we need to go for Weber test. And in Weber test, we will place the tuning fork in the center of the forehead, and then we will ask for lateralization. Normally, there should be no lateralization, right? But suppose if the patient has come to you with right disease in the right ear, and if the sound is going to right, then you will say there is right conductive hearing loss in the right ear. So if the lateralization is occurring to the opposite normal side, this is SNHL in the diseased ear, right? So this is how you need to interpret Weber's and Rennie's. Okay, so very easy to understand. It's just a matter of revision. Then there is one caloric test, or what we call bithermal caloric test, or Fitzgerald-Halpike maneuver, which is actually done to check vestibular function. And what we do here, we will put the water in the external ear, and the purpose is to stimulate the horizontal or the lateral semicircular canal, right? So for this, since the term is bithermal, so it means we are using two temperatures of the water. One is 30 and second is 44, right? So what we need to do, like room temperature is 37, so -7 and +7. Clear? So that will give you 44 and this will give you 30. Clear? So this is how we check this, and this is, then we look for the nystagmus. If we are using cold water, now this is cold water, the nystagmus should be on the opposite side. So suppose if you are putting the water in the right ear, the nystagmus direction should be to the left ear, and this is warm water. If we put the warm water, the nystagmus should be on the same side. Clear? So this is the mnemonic cows. I think most of you must be already knowing this. Then moving forward to nose, and in the lateral wall of the nose, one has to be very good with the different openings, right? So here you can take different meatuses where a single opening is present, like nasolacrimal duct, it opens into the inferior meatus. Clear? Then there is one posterior ethmoid which opens into the superior meatus. Clear? So you can remember posterior ethmoid here. Then the sphenoid sinus, this is the sphenoid sinus, and it opens into the supreme meatus or sphenoethmoidal recess. So this will open into the supreme meatus or sphenoethmoidal recess. Clear? Now all the remaining sinuses, they will open in the middle meatus. So if you have a question about opening of sinuses in the lateral wall of the nose, just remember these three, and all the remaining you can put in the middle meatus, right? So it is maxillary sinus, anterior ethmoid sinus, then frontal sinus. Okay, so all they open up in the middle meatus. And in relation to middle meatus, you need to remember two terms. One is hiatus semilunaris, clear, and another is bulla ethmoidalis. Clear? So the two terms you need to remember here. One is hiatus semilunaris. So and second is bulla ethmoidalis. Okay, right. Then moving forward to sinusitis. Again, if there is any mucopurulent pus in the middle meatus, that is suggestive of maxillary sinusitis. Usually frontal sinusitis is not seen at birth in a newborn, and the most important thing about frontal sinusitis is periodicity. Periodicity means it will show a specific course of symptoms, and this means that the headache will start at 9 a.m., it will peak at 1 p.m. and it will disappear by 5 p.m. right? So this is the course of headache of frontal sinusitis, and since it resembles with the office hours, because these are all 9 to 5 is all office hours, so the colleagues, they will presume as if the person is not yes, the order is MESF, very good. So the colleagues will feel as if the person is not interested in working in office and he is just making an excuse of headache. So therefore it is known as office headache. Clear? So please remember frontal sinusitis. And there can be one complication like frontal bone osteomyelitis, which can give to Pott's puffy tumor. Fine. So this is in short about sinusitis. Then moving forward to Epistaxis, that is blood coming out through the nose. We have two varieties: the anterior epistaxis, which is yes, mucocele can be seen. Anterior, which is arterial, and posterior through the Woodruff's plexus, that is venous. So anterior, most common site is Kieselbach's plexus. This is actually plexus of arteries, and the important site is Little's area. Now this is the Little's area, which is in the anteroinferior part of nasal septum. Now what arteries are contributing to this Little's area? Now here, before we go for those arteries, it's better you take one artery first which is not contributing here, and this is the posterior ethmoidal, right? So see, the posterior ethmoidal artery is not reaching up to the Little's area. So many times we have an all accept question, and the answer in 99.9% of the question was always posterior ethmoid, right? So either you remember this fact, or if you want to remember more, you can remember all the four arteries which are contributing to this little area. Of course, the one is anterior ethmoid, then there is one superior labial, then sphenopalatine, okay, and the greater palatine, right? So sphenopalatine and greater palatine, clear? So and sphenopalatine, like this, okay? So these are the four arteries: sphenopalatine, greater palatine, superior labial, and anterior ethmoidal. The only thing which you need to remember, that not posterior ethmoidal. And if there is a question, you can save a lot of time, right? So just remember this particular fact here. And this anterior epistaxis, this is anterior epistaxis actually, and posterior is through Woodruff's plexus, which is a venous connection. So this is Woodruff's plexus, and this is a venous blood in epistaxis, clear? Then again and again epistaxis can be seen in DNS, atrophic rhinitis, or maxillary carcinoma especially, and in a pubescent male somewhere in the age group of say 12 to 17 years, if you see a case with recurrent epistaxis, it can be angiofibroma. Yes, Anas, absolutely right. Then in children, usually it is because of trauma, but in elderly, it is because of uncontrolled hypertension. Then moving forward to nasal allergy, where we can see that the mucosa of the nasal mucosa is pale, edematous, and boggy, right? So it has swelled up. So this is classical of nasal allergy. Then depressed nasal bridge, that is also known as saddle nose. This is seen in trauma, abscess, or syphilis, clear? Then there is one jar-away fracture of the nasal septum, where you can see a horizontal fracture line. So this is jar-away fracture. Then moving forward to one condition, and that is a very important condition, CSF rhinorrhea. We already discussed CSF otorrhea, but here it is CSF rhinorrhea. And what happens? This is cribriform plate of ethmoid bone. On the top of that, so this is cribriform plate of ethmoid. Clear? On the top of it is the anterior cranial fossa, which is having CSF, and below is all the nasal cavity. So what can happen if there is any fracture in this bone? The CSF can leak out through the nose, and the condition is known as CSF rhinorrhea. Clear? So this is CSF rhinorrhea. So in traumatic cases, it is the cribriform plate fracture which results this. Then beta 2 transferrin levels are high. Then we can see one halo sign, especially if it is traumatic, and then the nasal discharge cannot be sniffed back if it is a CSF, and doesn't causes hardening of handkerchief if it is taken on a handkerchief. Clear? So these are two features which indicate that the fluid which is coming out through the nose is CSF and not nasal secretions of allergic rhinitis or other condition of related to nose. Clear? So it cannot be sniffed back, and it does not cause hardening of handkerchief. Clear? So this is CSF rhinorrhea. Okay, then moving forward to rhinoscleroma, and this is also known as woody nose. Clear? So you can see here, this is the woody nose. And here, if you do histology, you will see Mikulicz cells or Russell bodies. So anyway, Mikulicz cells are important here. Then another condition is atrophic rhinitis, and this is also known as merciful anosmia. Now atrophic, there is atrophy of bones and there is atrophy of nerves. Because of atrophy of nerves, there is anosmia. The patient cannot sense the smell. And because of atrophy of bones, actually, especially turbinates, there are two things. One is that the nasal cavity will become wider. Clear? So you can see these are very small turbinates. So these are atrophied turbinates. But you look normally, the turbinates are so big. These are the normal turbinates here, right? So what happens because of this shrinkage of the turbinates, the nasal cavity becomes very big. So if you see here, the nasal cavity has become so big, and this is known as roomy nasal cavity. Clear? So this is roomy nasal cavity. This is one thing. And secondly, because of atrophy of turbinates, there is bad smell. And therefore the patient's relatives, they will run away. But the patient, since he or she is having anosmia, so he cannot or she cannot smell that, and therefore it is merciful anosmia. Then a classical presentation of mucormycosis, which is especially seen in uncontrolled diabetes or any condition where there is immunosuppression. Okay, so this is mucormycosis. Just a 2 minutes break. I'll be back. Okay, we can start then, right? So black scars in nasal cavity, especially in diabetics, think of mucormycosis. And few years back, this question was framed, especially in relation to COVID as a complication of COVID-19 infection, right? Then there is one condition, that is Ludwig's angina, and here you can see edema in the floor of mouth, especially involving the submandibular and sublingual spaces, right? Then moving forward to ranula, which is a retention cyst. So this is ranula. You can see a bluish swelling here. So this is sublingual, means below the tongue, and this is a retention cyst. Of course, the most common tumor is oral cavity. Then here you can see a leukoplakia. Clear? And this is counted as one of the pre-malignant condition. So leukoplakia. Another condition is erythroplakia. Now erythro means red, so it will appear red, and it carries more malignant potential as compared to leukoplakia. So it has more malignant potential. And another condition is oral submucosal fibrosis, which is related to betel nut chewing. Then moving forward to pharynx, again it has three components: nasopharynx, oropharynx, and hypopharynx. And in nasopharynx, which is a oval shaped cavity, the important landmark is opening of Eustachian tube. So this is very important here, Eustachian tube. Then moving forward to juvenile nasopharyngeal angiofibroma, and it is especially seen in pubescent males. Although this condition is benign, but it is very vascular, and therefore it has two implications. Patient presents with recurrent epistaxis, and secondly, if you do biopsy, it will keep on bleeding. So therefore it is said that please don't do biopsy. So this is juvenile nasopharyngeal angiofibroma. And on CT scan we will see a classical Holman-Miller sign where the tumor mass is actually pushing the posterior wall of the maxillary sinus anteriorly. Okay, so therefore it is bent forward. Normally if you see, this is the normal side, it is curved backward, but here it is pushed forward. So this is the Holman-Miller sign seen on CT scan. And this tumor arises from the posterior part of nasal cavities close to the sphenopalatine foramen, and since biopsy is contraindicated, so we can go for CECT and we will see the classical Holman-Miller sign. And although this is radio sensitive, but we prefer doing surgery. The nasopharyngeal carcinoma, it is bimodal. It means there are two age groups which are affected. One is elderly, and sometimes it can be seen in adults as well, right? And this is in close relation to one fossa of Rosenmuller. So this is the important site in relation to the Eustachian tube opening. So this is fossa of Rosenmuller, and remember it for nasopharyngeal carcinoma. It may be associated with Epstein-Barr virus infection or serous otitis media, because there can be compression over the Eustachian tube and it can lead to blockage of the Eustachian tube. There is one trotter stride, I think everyone must be knowing that. There is conductive deafness just because of serous otitis media. There is palatal palsy and temporoparietal neuralgia. Then moving forward to peritonsillar abscess, which is also known as quinsy. And if you look here, this is the tonsil. Okay, so this structure is the tonsil, and this all is the abscess here, right? So this is the abscess here. Now it is usually because of streptococcus, but what we need to do, we will give antibiotics, or we can do IND by Hilton's method. And if we plan to remove the tonsil, we should do after a gap of 6 weeks, and that is known as interval tonsillectomy. So it should be done after 6 weeks. And here this the surgery is quite easy because the abscess itself creates a plane for removal of tonsil. So that's good in one way from surgical point of view, right? And this is quinsy. Then moving forward to larynx, the abductor of larynx is posterior cricoarytenoid. I think everyone must be knowing that. And since it abducts, so it is also known as safety muscle of larynx. Clear? Because it abducts the vocal cords. So it takes the vocal cord like this. Then all muscles of the larynx are supplied by recurrent laryngeal nerve, right? So this is recurrent laryngeal nerve, and there is only one exception, that is cricothyroid, which is supplied by external laryngeal nerve. Then lining of true vocal cord is non-keratinized stratified squamous. Otherwise, respiratory passage is usually lined by pseudo-stratified ciliated columnar, right? So this is in short about anatomy. And then moving forward to laryngomalacia. Now malacia means weakness. So what happens when the child breathes? There is inward, or you can say there is collapse of the supraglottic area, and that what gives a omega shaped appearance to the epiglottis. So this is known as omega shaped epiglottis, and this condition is the most common cause of inspiratory stridor in newborn. And treatment wise, we need not do anything, just wait and watch. The condition will resolve by 2 years. So need not do any active intervention. Inspiratory stridor, very good. So this is inspiratory stridor. Fine, great. Then vocal cord paralysis, since the recurrent laryngeal nerve supplies the vocal, it's the abductor of vocal cords actually. So any surgery or any tumor which involves injury to recurrent laryngeal nerve, that might call vocal cord palsy, especially so malignancy or removal of thyroid gland in case of malignancy or hyperthyroidism. Now moving forward to epiglottitis, and here we can see a classical thumb sign because of enlargement of the epiglottis, and this is a very important condition because it can lead to airway obstruction, and that may result in the death of the child. So thumb sign, yes, of course. So this is epiglottitis. Then coming to the neoplasm of larynx, most common varieties is squamous cell carcinoma, and there are two varieties to discuss. One is supraglottic, that is above the level of vocal cords, and here the most common presentation is pain, and along with that there is early lymphatic spread, right? So because of this the prognosis is poor for supraglottic variety. It may involve epiglottis also or any supraglottic area, but the tumor which is involving especially the anterior part of the true vocal cord, right? So this is the vocal cord here, and here you can see that this is the tumor mass. So it is involving the vocal cord, right? And as a result of it, it affects its vibrating capacity, and therefore there is a change in quality of voice. So this result in change in quality of voice, right, which we say hoarseness of voice. And this change in quality of voice is actually in one sense good, because the patient reports early to doctor, and therefore the condition is diagnosed early. Clear? So condition diagnosed early. And for tumors, if you diagnose a tumor early, obviously the prognosis is good because treatment is initiated early. And this fact, along with no lymphadenopathy, adds to the best prognosis for glottic carcinoma, right? So supraglottic and glottic. Then in laryngeal tuberculosis, you can see turban epiglottis. Clear? So you can see something like a turban epiglottis appearance. And mammillated or turban epiglottis, please remember it for laryngeal tuberculosis, right? So I think this is enough for ENT from my side. Very shortly I'll be back with another subject. Till then, keep on studying. Stay blessed. Goodbye.